I am Meredith Hirsh, and this is Working Healthcare. I'm opening today's conversation where I usually end it. Each week I ask the same question. If you could create one change in the American healthcare system, what would it be? In July, I posed that question to about 30 attendees at the Florida Medical Association's annual meeting. Dr. Arthur Palamara didn't hesitate. He told me insurers have done the greatest harm to patients and physicians, and if he could, he would remove insurance companies from the middle of care because their focus on profitability too often undermines the patient. Arthur is a vascular surgeon who has served on staff at Memorial Regional Hospital in Hollywood, Florida since 1979. He has watched insurance evolve decade by decade, from simpler benefits and fewer barriers to today's dense networks, prior authorization hurdles, and higher out-of-pocket costs. He's lived the shift, and he has a lot to say about what's changed and what matters now. Here's why we need his perspective. The average annual healthcare bill for a family of four costs a staggering $25,600 a year. And after care is delivered, insurers on the federal marketplace still denied about 1 in 5 in-network claims this past year, a stark reminder that profit-driven gatekeeping can erase a physician's judgment with a single click or an AI-generated algorithm. Arthur has navigated insurance companies from the OR to the committee room. As a longtime leader in organized medicine, where he has served as vice president and on the board of governors at the Florida Medical Association, a delegate to the American Medical Association, and president of the Florida Vascular Society, he has fought these policies up close while caring for patients in the hospital. Today, we will pull apart the playbook of modern insurance. We will examine prior authorizations that second-guess doctors and stall essential care. We will trace how narrow networks fence patients in, how formularies push step therapy, and how endless portals and peer-to-peer reviews siphon hours from exam rooms. We will look at Medicare Advantage's growing footprint and the real-world consequences for referrals, imaging, and post-acute care. And we will talk about what's salvageable, where oversight could be smart and swift instead of opaque and punitive. When an insurance company denies care, that's not a glitch. It is the system working as designed for investors, not for patients. Here is my promise for today's conversation. We will name the harms, spotlight the fixes, and provide a peek into the history of the American health insurance industry, because you can't fix what you don't understand. Dr. Arthur Palamara, welcome to Working Healthcare.
Meredith, it is a pleasure being here, but I think you need to change the name of your show because healthcare is not working right now.
I know, and you have been a big proponent to try to fix the system for decades. And I really wanted you on the show because I wanted to talk about a couple key points. One, I do want to talk about the importance of physicians getting involved in organized medicine and how they can band and work together. But before we even get there, I want to know why it's not working. So what do you see has been the shift from when you started practicing in Bethesda, Maryland, to where you are today?
Approximately 27 years ago, when I was chief of surgery, they brought in an outside group, J.R. Sullivan. This company came around, did evaluations of hospitals, and they gave us a lecture. And the lecture was absolutely phenomenal. And they said, none of you are going to like this. They said, right now, we have a goal, and our goal is to take care of patients, to get them better. That is our product, to have a healthy patient. That's why you went to medical school. That's why hospitals exist. He said, what's going to happen over the course of the next 25 years is that you're going to see the goal change. It is no longer going to be patient care. It is going to be the maximization of profits. And that's exactly what happened. And it's getting worse and worse and worse every year. So instead of having the goal, you can only have one goal now. You can have multiple objectives, but you can have one goal. And that goal right now is profitability.
So what changed from, I'm going to say 1998, right? Because that was 27 years ago, to where we are today. And it's interesting that you bring that up because you and I both know Gene Acevedo. And Gene loves to talk about the history of where we were starting when we were trying to, quote, fix CMS and fix the Medicare physician fee schedule. But is that when it all started to change?
It started to change when I believe Wall Street and private equity firms and the big financial interest realized that medicine was consuming a large part of the GDP. And when they realized that there was a ton of money to be made there, and medicine, as you know, is kind of sloppy. Two doctors can look at a problem and come up with different solutions to it. So what happened is that they wanted to make medicine uniform, a guidebook, a strict formula that you had to follow to try to maximize the efficiency and thereby maximizing profits. And I believe that Governor Scott, when he was governor, he was actually, I think, president of a healthcare corporation. When he went to the first hospital, that he saw that and he saw all the waste that was there. He says, I can do better than this. And I actually was working at Biscayne Hospital. It was called Humana back then. And then at that time, they took up all of the bandages and everything that you needed on the floor, and they locked them up in a closet. And you had to find a nurse to go ahead and open that closet for. Otherwise, the patient may be bleeding to death, but you couldn't get it. So I think that's when it turned. And I think it's just gotten worse over the years. And as you know, it consumes, 25% or 30% of their GDP in the United States. And it's just a huge amount of money.
Yeah.
And the doctors are no longer players.
Yeah, and we're hitting nearly 20% of our GDP. When do you think physicians became a commodity? Because that's what I'm seeing right now, right? It doesn't matter who or what. Everybody will get paid the same measly amount. It doesn't matter if you're providing emergent service or you're providing a planned service. It depends not even the type of physician you are, right? It's the level of visit that you offer. So when do you think physicians became a commodity?
Two things happened. Actually, maybe more than two things, but let's start with one. Physicians had to pay a lot of money to go to medical school. We're the only country in the world where physicians have to pay for their tuitions. And they came out with $250,000 worth of debt. Number two, the practice of medicine has become increasingly complex. I'm going through it right now, reestablishing a solo practice. And it is much more difficult than it was in 1970, 82 when I started my own private practice. And then I kind of restarted it with a partner in 2010. And it's much more difficult now than it was then. And it is fraught with complications, with bureaucratic regulations that from the government, from the insurance industries, from conglomerations and what have you. And they keep on checking every few months to make sure that nothing has changed. So this complexity has forced doctors who are coming out bright-eyed and bushy-tailed, full of idealism, and then they have to try to start a practice, and they look at the complexities, the difficulty, and the cost, and they say, no, I'm just going to take a job. And then when you finish your residency or your fellowship, you got to start paying those loans back. $250,000. I think the average is about $270 right now. It's a lot of money a month.
It is. And you're a vascular surgeon. And what I thought was really interesting, you and I had this interview scheduled a couple of weeks ago, and we had to cancel because you had a case that was delayed, and it wasn't because of you or the previous case. It was because the hospital couldn't get an anesthesiologist.
That's correct. That is correct. But don't forget that anesthesia company is owned by a private equity firm, and they did not pay the doctors for a while, and they're kind of fighting their way back right now. It's called Envision, and they were kicked out of California, incidentally. And I think they try to do a good job, but what really got me, they were owned by KKR, and then KKR stopped loaning them any more money, so they stopped paying the doctors for a while. Of course, some of the doctors got upset, and they left. So what happened was that they wrote off about $2 billion worth of debt. Poof. I'm not sure you do that. Where'd it go? But it was gone. So they're kind of fighting their way back. I think they sold one of their units, the surgical unit, an ambulatory surgical unit, and I think maybe they kept themselves whole like that. But they're still out there fighting. And I've been pleading with the organization where I work, hire the anesthesiologists, make them part of yourself. But for some reason, they did not want to get involved with that complexity. And then secondly, about pertaining to the anesthesiologist, anesthesiologists are not paid enough to hire an anesthesiologist. The reimbursements from Medicare and from Medicaid are so low, they can't possibly exist.
So if we look at hospital care, or
Right.
obviously you need an anesthesiologist to perform any type of surgery.
Yeah, they don't allow you to put a piece of wood in somebody's mouth anymore. You
You can't do that and just say, just clamp down really hard, right?
Yeah.
Like the movies I like to watch, the old time movies. So let me ask you though, you're waiting for the anesthesiologist. The hospital doesn't hire the anesthesiologist directly.
Right.
They're hired through a third party.
That's correct.
Is that how it works at most hospitals?
I can't speak for most hospitals, but I would say probably yes. Yeah.
And so what about vascular surgeons? Because you were in your own practice.
Correct.
You now work at the hospital, and you said you're looking again to start your own group.
No, what happened was that I saw the writing on the wall, and it became increasingly difficult to maintain a private practice. I also saw, too, that the compensations, the remuneration from the insurance companies were way, way down. So the writing on the wall was to go to work for a hospital. And my partner and I, we got along beautifully. We had a beautiful practice running, but we had to realize that the opportunities were no longer there. And then you have to fight with every insurance company. If they don't like you, then they throw you off the panel, and it just makes it increasingly difficult and complex. So the hospital came to us and hired our practice. Didn't buy us, they just hired us basically. And so I practiced with them for 12 years, and then they decided that they didn't need me any longer. And I was getting too old, I guess. But anyhow, but I haven't lost my skills, fortunately. So the next day after my contract with them ended, I did 3 cases. And I just been kind of going along. But the compensation in the situation that I was in until, well, actually it's going to be till the 30th of September, the compensation was so low you couldn't exist. Fortunately, I live a very frugal life. I have a frugal wife, and we've put a lot of money away, so you don't have to worry about me. But for a new doctor coming out, to be able to be paid what I'm being paid right now, pay off the student debt, pay off a mortgage, have a wife, children, wouldn't be able to do it. It'd be impossible.
So the average annual premium for a family of 4 right now is nearly $26,000. Where's the money going? If the doctors aren't getting it, who's getting the money?
The money is going to the insurance companies, which have made undeniably unpardonable amounts of profit. That's where it's going.
So let's talk about Blue Cross Blue Shield and Cigna, because you're yes, exactly. You're at the Memorial Healthcare System.
Touchy.
And Broward Health already canceled its contract with Cigna and Florida Blue. And effective September 1st, Memorial followed suit.
South
We've already
Broward,
passed September 1st.
Yeah.
So no longer with Cigna and no longer in network with Florida Blue.
That
And
is
Joe
correct.
DiMaggio Hospital, people who are listening to this may not be aware, but that is the children's hospital in Broward County.
It is a disaster what we have right now. I feel so badly for the patients who have paid good money. And what is forgotten in that, too, that patients have confidence in their doctors and in the healthcare system. And you just can't change that like changing a pair of pants. It really takes an awful lot of time to build up trust, to be able to build up confidence in the physicians who are in the hospital and the institution. And you just can't go ahead and change it. So now Blue Cross and Blue Shield says, well, you can go to some of our other hospitals or providers that are able to provide the same care. But there is no equality among healthcare.
And it's not even that. So just a little background about Florida Blue. A year and a half ago, actually nearly 2 years ago at this point, our practice got a letter from Florida Blue stating that effective January 1st of 2024, we will no longer be in network with their Medicare Disadvantage plan.
And what percentage of your patients belong to Florida Blue?
So it's interesting that you ask. So it was, I thought, about 4%. And it actually it impacted about 8% of our patients. And this is why. It was hugely significant. And this is why. I don't know if the listeners are aware, but every state Blue Cross plan is how every other state Blue Cross plan is processed. So I have Florida Blue for my family. I see a doctor in Florida. my claim is processed through Florida Blue. If there's a retiree from Michigan who comes down and has Blue Cross Blue Shield of Michigan, the claim still processes through Florida Blue. It processes through the state in which the services are rendered. And so we not only lost 4% of, quote, Florida Blue patients, we lost 8% in total of every single
Nationally.
Blue Cross Blue Shield Medicare disadvantaged patient.
Yep. So our system of healthcare is so fragmented with the insurance company, it just doesn't work. It is not fair, and the patients are paying through the nose. And
So
they can't afford it.
is Blue Cross leaving the state of Florida? They didn't. First of all, I'm confused because the Hospital for Special Surgery, which is out of New York, but they have a location in Palm Beach, has never taken Blue Cross Blue Shield. We were just nixed from Florida Blue a year and a half ago for their Medicare plan. A huge hospital in Pensacola, Florida, which is, for those not familiar with Florida, is, gosh, a 9-hour drive from here. And that hospital, multi-specialty, was just canceled from Florida Blue Medicare.
That's why it doesn't work.
Exactly. Yeah. And you are in a huge hospital system, the largest hospital system in Broward County, and no longer take Florida Blue. So what do patients do?
They're out of luck, and I don't think anybody on Wall Street or people that control these companies really cares. I don't think they have a heart. I don't think that they have any compassion at all. And I think part of the problem is the fact that they are so ivory towered on the 30th or 40th floors of their buildings that they don't really know what's going on the street level. And they should. I mean, I don't. Well, what happened a year ago, December, when Mangione shot the executive from United Healthcare. I mean, you can't condone violence, but you pull the scab off of a festering boil, and the people were very sympathetic to what he did. I don't think they liked it either. None of us would advocate killing someone for that, but it revealed actually the depth of the problem of healthcare in this country. It's unaffordable.
But nobody is still doing anything about it.
Nothing about
and
it.
I don't quite understand. I talk about...
We're sitting here trying to do something
We
about
are, because I talk about our best and our brightest no longer going to medical school. Why did you choose to go to medical school?
I'm not sure, but... I kind of liked it, and then the more difficult it became, the more I liked it. It became a challenge, and it kind of fits my personality because I'm good with my hands. And just a quick story, though, about that.
I'd love it.
When I was graduating from high school, I applied to Seton Hall University. I was at Seton Hall Prep at the time for English. I'm pretty good in English. And I applied to Notre Dame for aeronautical engineering, and I applied to Fairfield University in Connecticut for pre-med. So Seton Hall accepted me. So back in those days, if you were rejected, you got a kind of a smelly envelope with a single piece of mimeograph paper that said you were rejected. I got a thick letter from the dean of the School of Aeronautical Engineering. And in there, the cover letter says, "We really can't understand how your guidance counselor allowed you to apply." And they said, if you wanted to, we'll send your application over to the School of Liberal Arts, and then Fairfield accepted me. So that was very interesting, and I got in there, and then I was usually pretty good in sciences, so I stayed there, and as the curricula got harder and harder, it became more challenging for me to say, I really want to do this. So then when I got into it even more, I didn't even know what I wanted to do. So when I applied for my residencies and so forth, I was going to take anything. Actually, I started out in internal medicine. Should I go on?
You can. I was thinking you went into internal medicine. My husband actually went into pathology.
Stop. Hold that thought. So here's what happened. So I'm in internal medicine, and we're rounding on this poor guy with end-stage chronic obstructive lung disease. Every day, 6 o'clock in the morning, we're having the same rounds, the same discussion with different attendings. So after a month, I had been up all night. I slumped to the floor. And the doctor said, "Dr. Palamara, are you okay?" I said, "I can't take this anymore. We've had the same discussion for the past month. All we do is this over and over and over again. And then seeing people in the clinics, they're not really sick. Well, my people are really sick." So I left that. I went to Harlem Hospital in New York and became a surgical intern at Harlem Hospital in New York, which was part of Columbia Presbyterian, which opened up all the doors for me. Well, after 6 months there, And I was the best intern. By the way, I worked harder than anybody else. I didn't like that. So the chairman of the Department of Surgery at Harlem Hospital said, go over and see the chief of pathology at Columbia Presbyterian, talked to him. His name was Lattice, Arthur Lattice.
If you were bored doing internal medicine, I can't imagine pathology was intriguing.
It was very, oh my God.
Really?
Oh, I did it. I did that for a year. And they started about 9, they listened to classical music, but it's really an exercise in your head. It teaches you how to think. I mean, you see the patient from beginning to end, even doing autopsy on them. So I had 5 jobs while I was a pathology resident. Okay, then I went back into surgery, and I've stayed there ever since.
Yeah, it's like Quincy, right? You just wanted to be Quincy.
Well, it was fun. I'm serious. I mean, you look at the slides, and a good pathologist, they can take a look at a slide and tell you 20 things about the person.
Oh,
it's phenomenal.
I think by Mark's 1000th, I don't know, he's shared the story. He's like, I just was shaking my patient going, I just need to speak to somebody. So he decided maybe internal medicine, and then he'll do a subspecialty.
I couldn't do that. No, for a while, I actually had a primary care doctor in my office when I was solo. And I looked at his patients. I said, your patients don't need a doctor. And he goes,
Exactly. It's like psychiatry and trying not to fall asleep. That's what I hear from people. So there's definitely a reason why people navigate to certain specialties.
Yeah.
And going back, specifically talking about surgery, you don't really have a choice as to who you care for, I would think, in vascular surgery.
Well, I don't take ER call anymore, which is one of the good things about not working for the hospital. But you're right. I mean, whoever kind of walks into the door, you have to take care of whatever they have. And vascular surgery is really, really, really varied. You have no idea. It covers the entire body. It covers every organ. You have to be knowledgeable of each one of them and all of it. And it's just a lot of fun because of its challenge. And it's kind of like trying to figure everything out and then how it interplays with every other organ system. So it doesn't really pay anywhere near as well as, say, as cardiac surgery. But I think the challenges, which I could have gone into also. But no, I mean, they do what? 3 operations generally, either valves or coronary bypasses, sometimes an aneurysm like that. For the most part, it's bypasses. I think I probably they use a saphenous vein to do bypasses on the heart. I probably harvested maybe 2 or 3 miles of saphenous vein from people when I was in my training. But anyway, I said, I don't want to do that. So I went into vascular surgery.
So you've been a vascular surgeon ever since. And so for the patients who do not have health insurance, how do you get paid?
I don't.
So how does that impact the overall coverage? And I think about that with anesthesiology. You said anesthesiologists don't get paid enough. So what happens if they're covering for a hospital and they have a case and they take care of the case and the patient doesn't have insurance? Does the hospital supplement the anesthesiologist?
That was exactly the word I was going to use. They supplement it. They have to. Even the contract has to be supplemented, yeah.
And so it's going to be very interesting with the One Big Beautiful Bill. I had a previous guest on and we discussed it, and it's really going to impact hospitals and specifically rural hospitals because
it's a disaster
of the supplementing of those who are underinsured or those who are uninsured.
I think 800 have already closed the rural hospitals, and they're expecting another 1,000 to close. It's going to be a disaster. It doesn't work at all.
And so we're decreasing Medicaid benefits to patients. Insurance companies are...
$14 million they expect to lose, right?
Insurance companies are really strong-holding physicians and hospitals. And what do we do regarding prior authorizations or approval prior authorizations or referrals or any of the other regulations that actually stops care from occurring?
Okay, you brought up a very touchy point over here. Insofar as prior authorizations, they already have formulas in place using AI, and they can deny a claim in 1.2 seconds. And you may or may not know that United Healthcare bought Interqual, which is the organization that determines the medical necessity of doing a procedure. Now, some of the physicians have responded, unfortunately, maybe a bit unethically, of doing too many procedures or minimally indicated procedures just to try to make up the loss. And I cannot sanction that. Again, as a profession, we have to do what is right for the patient. And if we do that, we will succeed and the public will support us. When we start to step over that boundary, we will not. So what do? You can try to have a peer-to-peer, but then you spend more time trying to get to prior authorization than you do actually doing the procedure, taking care of the patient. And that is economically just not feasible.
And then what do you happen when you're wheeling a patient into the OR and all of a sudden the prior authorization is pulled?
You want to tell you, what I'm going to say, I'm not going to advocate. You've heard of EMTALA?
No.
Emergency Medical Treatment Act?
Okay. Yes. Thank you. All of these acronyms very much confuse me.
Well, God bless the United States Congress for passing it. I think it was 86. So if the hospital offers a particular specialty or service, then somebody comes into the emergency room, you cannot turn them away. So if somebody comes in and needs a heart transplant, let's say, and your hospital doesn't do it, they can obviously, you got to go to a different hospital. But if they come in there, let's say, and they have a herniated disc and your hospital does neurosurgery, you got to keep them. So in my particular case and so forth, and the hospital's been very nice to me. I probably shouldn't say this on air, but the hospital's very nice to me. If somebody needs an operation, we don't take their insurance. I've operated on them before. I have a personal relationship and an obligation to take care of that patient. Come in through the ER.
So what happens with the hospital? So I'm thinking about transplants in particular.
Yeah.
I have a speaking engagement coming up with the Coalition of State Rheumatology Organizations, and I'm interviewing Wendell Potter, who was on this podcast as well, and he discusses the fact that the reason why he was done with Cigna, and he actually was the head publicist for Humana and then for Cigna Health, but he's like, I can't take it anymore because a young girl, while she was getting wheeled in for a transplant, Cigna pulled the prior authorization. So what do you do? Who's paying for any of this? My concern is you're going to go bankrupt. The hospital doing all of these good deeds will go bankrupt, and the greedy insurance company is going to prevail.
No, they'll sue the insurance company and they'll get paid for it. In fact, even
I don't know about that.
I think so.
I'm telling you, I am struggling so much. So here's some new information that's happened. Cigna and who else is doing it? Cigna and Aetna, effective October 1st, are going to downcode without reviewing medical records if they feel historically you are billing too many level 4 or level 5 office visits. Maybe even a level 3, I don't know. They'll just randomly start to downcode.
Do you want to define for your audience clawback?
Oh, clawback is terrible. And I will tell you, Dr. Nate Lowen was on the podcast talking about clawbacks because he is a spine surgeon. And he can't even take care of United Healthcare patients anymore.
Define that for your audience.
So clawbacks are when insurance companies have paid for the service, and then after the service was already paid and taken care of and long gone and the check was cashed, the insurance company comes back and actually takes the money back.
It is an unholy system.
It is horrible.
And you just can't exist like that. And what I think needs to be explained too is the fact that because of the prior authorizations, the number of people that you have to hire to be able to make sure that the insurance company is going to pay for it. And then if they don't pay you, you have to file claims again. You have to hire more people to do that. So the system is just fundamentally, irremediably broken.
Oh, it's not even that. Today, I had a meeting with our accounts. Our
accountant?
No. Our RCM manager, our revenue cycle management director, and we were reviewing AR. And I saw this infusion claim from 4 years ago on our AR. And I said, what is this claim doing on our AR? And she said, oh, they clawed back the money.
Excuse me.
It was a clawback. It was an insurance company, I believe it was United Healthcare, who clawed back the money and said, no. The patient we incorrectly paid the claim. The patient had Medicare at the time. By the way, the patient did not have Medicare at the time. We had a prior authorization and the patient had United Healthcare, and they're just taking the money back.
Yep. That's the way they operate.
And then we have to hire people to go fight it. So when you said that, the hospital will just sue the insurance company and get the money. No, they won't. And the amount of money the insurance company has over the hospital, over a practice like mine, we can't even compete.
Well, at least you have margin. You have a pretty big group, and there's not enough rheumatologists around, right?
It's very difficult. We're not at the hospital. I mean, I don't know any rheumatologists right now that are at the hospital. They're not hospital-based.
We have one comes in by a very good lady, by the way, does a good job. But no, it's a very difficult profession. It's very difficult to get paid.
So that brings me to Medicare. So we have traditional Medicare for patients or Americans once they're 65 years of age. Medicare Advantage or disadvantage plans continue to rise, and those are private insurers. How's this going to change our system?
Medicare doesn't pay enough to stay in practice. That's the other part of the problem. And doctors have not had a raise since 2000. Mm-hmm. And if you combine that with inflation and so forth, we're probably gone up maybe 6%, whereas the cost of living has gone up 30%. You just can't exist like that. It's just economically impossible. And then you couple that with your debt to pay off your medical school loans, it becomes a complete disaster. And unfortunately, there's not going to be anybody else there to take care of the patient. That's the problem that we have. So
that's exactly why I started working healthcare.
So are we going to come to a solutions part of this?
That's what I do. So I really want to ask you before we come to the solutions, of all of these challenges going on, in 2025, what has been your biggest challenge?
My biggest challenge, I really can't say that. I think the insurance companies and the hoops that they make you jump through is probably one of the largest. Secondly, the hospitals too. The hospitals have not allowed us to become advocate for our patients, and realizing that medicine and healthcare is a big business. I'd like to point out something, which you probably read the article because you're smart and you're well read. Article last week about a nurse in Palm Coast who wasn't a nurse. Mm-hmm. And she practiced for 6 months. She got promoted, and they offered her a higher level job, and she wasn't even a nurse. The real problem is that the staff, the really true well-educated, well-experienced nurses are few and far between, maybe 10, 20%. And they knew what was going on. Nurses that we have today are coming out wet behind the ears without sufficient training, and that is all the hospitals have to work with right now. So if you criticize the nurse because she or he didn't do what you want, then the doctor gets in trouble, and they are called, a physician who doesn't cooperate.
Well, it's really interesting. I had Dr. Rebecca Bernard on the podcast, and I know you know who she is. And she spoke a lot about the difference between even a nurse practitioner and a physician, and how little training nurse practitioners actually have to have, and hands-on training. So we're not even talking about registered nurses. We're talking about actual nurse practitioners and giving them the ability to practice like a physician.
They have it. Which I didn't know until recently. But yes, they can open up their own independent practice. In fact, somebody's opening up a practice here in Palm Beach County. In fact, a nurse practitioner. And nurse practitioners with whom I have worked for the past 50 years, if they stay in their lanes, what they're supposed to do, are excellent. Mm-hmm. They do a wonderful job. They work hand in hand with the physicians, and it is a symbiosis which works out beautifully. But the problem is they don't know what they don't know. And there is kind of an arrogance because you see all of these, people, let's say, with broken legs, and then somebody comes in, the leg isn't broken, but they have no circulation. They are not mentally aware to be able to look for that because they are not challenged with the diagnostic challenges or with the treatment challenges. They learn a very small set, and they're very good at what they do. But to put them into an area where you have to kind of expand your thinking paradigm, they don't do very well there. So consequently, they are dependent upon using much more consultants and using many more diagnostic tests.
So let's talk about what we're doing right. What do you think we're doing better now in 2025 than we did when you joined the practice?
You could define that better than me because your specialty of rheumatology has so many new, what they call the antibodies, the
monoclonal antibodies.
I mean, it costs a frickin' fortune. I don't know how you do that, but the science has gotten much better. We've been able to refine down some of the mistakes that we made when I first started practice. We don't make those mistakes anymore. Procedures have become a lot more systematized, a lot more organized, and if you work with a team, the outcomes are much better. Some of the mistakes that we made, anesthesia being one of them, we've developed new technologies to be able to protect patients. Instead of doing a lot of major operations, we can do something called endovascular, put a balloon or a stent in. That works very well. So we've seen tremendous progress in that realm. Pacemakers used to be huge things. Now they're very tiny and very small. They're horribly expensive. Balloon angioplasty and so on and so forth. All of that is to the better. It has really protected the public. It's really helped the public. And things like your Wegovy to lower your cholesterol, those are medications which weren't even thought about 20 years ago. Antiplatelet medications that we use, lowering the cholesterol even with a regular statin, things like that have enjoyed a tremendous success. You want to talk about vaccines too, or is that a tender subject?
Oh gosh, vaccines and the CDC and everything going on.
I saw what our Surgeon General did today?
Oh, I definitely need to run the Health and Human Services. I think we can all agree
Here
that
in the state of Florida,
RFK is challenging us.
Latipo, I think his name is.
What
Dr.
happened
Latipo?
today?
They're taking away the requirement for children that go to school to be vaccinated. They'll no longer have to be vaccinated.
So what are we doing with polio? What are we doing with measles?
I don't know how religious you are, but I want to start there.
I'm like, oh my goodness. I mean, my kids are younger, but it's really a problem.
So if a child wants to go to kindergarten or something like that, doesn't have to be vaccinated.
Do you have to show some type of religious exemption?
No.
Anybody.
Nothing, right.
So we'll just start walking around. People are going to start getting polio.
We're going back into the dark ages of science. We are.
I just don't understand. Let me ask you, if there were additional requirements, I'm going to move beyond the CDC. I can't even deal, and with our Surgeon General. If there were specific requirements by insurance companies to post their denial rates or post and make it public knowledge what they are not approving, do you think there would be a change?
For a while, till they would figure out a remedy to go around it. Excuse me.
What can we do? What can either the state do, the U.S. government do, our politicians? Can we do anything? What can doctors do?
Well, that's a very pointed question, which I'm trying to do something about. I'm trying to motivate the American Medical Association to pick up this responsibility and challenge and become an advocate again, become the stewards of medicine, and to lead the charge and protect patients. We've lost that. For some reason, we've become too acquiescent to what is going on around us, to allow the insurance companies to dominate, to allow the federal government to dominate, and so on and so forth. And we have lost our moral responsibility. Somehow our code has been ruptured. So I'm trying to push them to go ahead and say, we're not going to take this anymore. And now we're going to start to fight. I mean, all we would have to do is just not sign a consult or an order. You can put pending approval or something like that on there. We would throw the entire system into chaos.
Yeah, but then you're not caring for your patients.
Yes, you are. You're just not signing for it. You're giving the patient the care and everything. Okay, so the orders you have to sign, but the consults of the hospital can't bill, so the insurance company, the whole thing would go into chaos. But unfortunately, then you wouldn't get paid for a while. So at a certain point in time, we're going to have to put on our big boy pants. We're going to have to say, stop, we're not doing this anymore. We are going to now take back control of the practice of medicine.
So we're essentially going to strike.
Well, I would not use that word because I don't think doctors are mentally prepared for unionization either. I just want to give you one little tip you may not know about. AMA has been looking at this. They've had several meetings at their annual meetings and so forth with lawyers to try to figure out how to do that. And there is shared risk. There are exemptions. We probably could get an exemption like the baseball players. But yes, that would probably help. But it's still going to be up to the fundamental responsibility of the doctor to exercise their oath, their responsibility. And that, I think, would be the quantum change.
So you've been involved in organized medicine really your entire career.
My entire career.
Why are younger physicians not getting involved?
You know, we started that topic of conversation and I lost the chain of it. There has been a significant change with our young people. They're not joiners. They don't like to expose themselves or their ignorance or take a risk. They're not risk takers. Number two, they don't ask questions. They don't want to challenge authority. Well, why are we doing this? They don't do that anymore. They're very obedient. They just are very...
They acquiesce.
That's the word I was looking for. Thank you.
It's really a challenge, and I just had a conversation with somebody earlier today. I was very frustrated. She said, "Don't you have an assistant?" I said, "Oh my God, don't even go there." I tried like 3 years ago. I tried twice, 4 years ago and then 3 years ago, and I just gave up. And she asked me why. And I said, you know, the work ethic has changed and the desire to get answers and to even learn from mistakes, create learning opportunities, that has changed. And so she said to me, "Why do you think it changed?" I said, because we're in a society now where everything is immediate and you can get Amazon and you can go onto Google and find the answer. I remember when I was in college and I had to take the entire day and go to the library and look at a microfiche and try to figure out what the answers are, right? And look and understand the Dewey Decimal System. I didn't have Google.
We lost that inquisitiveness.
Yes, and the ability to make, as you said, mistakes or to go out and venture and understand why. How do we get it back?
I think that in our schools, I think we better start with our schools. I think that they need to teach kids to use the critical thinking skills, number one, and to challenge authority. Well, why do you say that, Professor? You know, it doesn't really make any sense to me. And we used to do that. I mean, I lived in a civil rights era, two-man challenge it. So, but they don't do that anymore. I mean, I guess I feel comfortable in my own skin, and I've been beaten so many times that the scars on my back have all healed, and I'm still here. I mean, Marco Rubio, I remember once with him. He was running for Senate. He's at the FMA looking for support with our flam pack. So it was a Saturday morning. I'm dressed in a blue shirt and khaki pants. He's dressed in a blue shirt and khaki pants. He's up there talking. He's a very nice person. Have you ever met him?
I have.
He's a delightful person. You just cannot not like him. And so he's up there and he's talking about the great care that his father was receiving with his stage 4 lung cancer in the, what is it called, Clinica Cubana. And he goes and he gets his little cafecito and he has that in the morning. He talks to all of his friends and stuff like that. And he just says how wonderful that is and so forth. And at the same time, this was, I guess, slightly before the Affordable Care Act and everything. But certainly Republicans were not really in favor of that at all, as we know. Are there any questions? Look, nobody. I've never lost an opportunity. I said, Mr. Rubio, I mean, you give a marvelous speech, and it's just impossible not to like you like that. I said, but let me ask you, why would you not want to give the rest of Americans the same wonderful care that your father's getting? And so he looked at me and kind of babbled or something like that, whatever. So after he was done with the presentation, so he walks down, he puts his hand on my shoulder and pats my shoulder, walks away.
It's because you have to pay for it. You have to figure out how to make adjustments to change the system.
Stop. Have to pay for it. We spend twice as much money on healthcare as any other developed country.
Oh, I'm not talking about us. I'm talking about the insurance companies. If they are covering and providing care, that's what they say. It's supposed to be healthcare. I know it's sick care. But if they are supposed to be providing care, they're the ones who have to actually give part of their the premiums, part of the collections that they get, part of the government subsidies that they get to provide insurance.
I don't think that's part of the contract. I mean, what, they maximize their profits at 15% for a small cap? I'm sorry, 15% for a large cap, 20% for a small cap, which they can keep as profit. But then the way they define their expenses remains to be decided.
Right.
And they just maximize the profitability. And who's paying for that? Joe Blow is out there either working in a job or paying money up to a month to an insurance company. The system, that's all the money is going to people, to Wall Street, and private equity firms, things like that. And that doesn't work.
Right.
So they're taking half of all this money off the top.
So if people got involved in organized medicine in these medical societies, what type of difference do you think could be made?
I think that since we are the only ones that can provide the care, they can't do it without us. Challenge the president of United Healthcare, or Blue Cross and Blue Shield, which is a nonprofit, by the way, Blue Cross and Blue Shield.
Blue Cross Blue Shield is a nonprofit?
Yeah.
No.
I'm pretty sure.
No, it isn't.
Used to be.
I'm gonna question you on that, but we'll have to do that offline.
Okay.
I'll have to provide information on my LinkedIn page to give listeners some more information on that. But I will do that, Arthur.
Betcha.
Okay. So tell me, what do we do?
What do we do?
Yeah.
We take back the reins and say we're not going to do it anymore. This is what we're going to do, and stop with the prior authorizations. I think this patient needs the procedure. Now, in their defense, I have to say that, well, let me back up a little bit. At our Florida vascular meeting earlier this year, we had a professor from North Carolina, and she gave this nice talk about people that do the vein surgery, the ablations, what they're called, the ELVS procedure.
Mm-hmm.
And most of the people are over here, and then you have the slope goes down like that, and you see some people at the end that abuse it. Well, then she said, these are the people, if we get rid of this, we can save $35 million. Doctor, $35 million when we spend about $35 trillion on health care? No, not that much. It's less than that. But on health care, that's going to make a dent in the mattress? No, it's not going to make any dent. It's not going to make any difference at all. But, I mean, you can get rid of those people. Some people have suggested what is known as a golden handcuff. You do 10 cases correctly that have been approved. If we're using a standardized formula for approval, for authorization, that would work. And then those people that are outside the bell curve, then we cut off their ability to do it. So that's one way of getting rid of some of the fraud and abuse and waste. And the insurance companies know it. You can tell. I mean, it's very simple to see that 100 people come in with varicose veins, and doctors operate on 15 of those people, and then another doctor operates on 50 of those people and does 4 procedures on the same person. You know who the people that are abusing the system.
Yeah, but I think that those abusing the system are the outliers, as you described in the graph. And so you are penalizing everybody
right now
for the outliers.
Well, that is I would say, the most generous way of presenting that argument. I would also say, too, that the insurance company is interested in their own profitability and their stockholders.
Yes. So let me ask you, since we are about creating change, I'm going to still end my question, this interview, in the same way that I end every interview, but with a little bit of a caveat. If you want to create immediate change right now, what is the one thing that you wish or you think others can do to create immediate change within our American healthcare system right now?
That's easy. Get the 1 million doctors in the United States to join the American Medical Association, pay dues, get active. And the strongest lobbying force in the United States is a doctor and his patient. You have trust, you have the ability to influence thinking, and the public is disgusted and they're waiting for leadership. And no one out there right now is providing that leadership. And I say to the president of the American Medical Association and to the people that control him, the board, and particularly the employees, assume that mantle of responsibility. Get out there, yell it from the rafters. We're going to take back the profession right now. We're going to do things what is right for our patients. We're going to be able to provide them the care that they deserve, the compassion that they deserve. That is what we're going to do. That is why we became doctors.
Well, I appreciate your enthusiasm. I appreciate your gumption and your desire to fight and your desire to create change and not stop.
I'm close.
I know.
I wrote a letter when I came back from the meeting and so forth. I'm saying, I've been coming here now for 25 years. I've heard the same speeches. We're not going to take this anymore. We're not going to take this anymore. And yet nothing happens.
Because it's the same people all of the time.
Yeah.
And that's the problem, right? The same people. I've been there for several years, but you've been there much longer than I have. And I know for the several years.
I'm talking about the AMA.
Oh, well, the AMA, my husband was a delegate this year, and I'm telling you, he got a little challenge because they weren't doing the fight the way that you were talking about. He was frustrated that they were focused on figuring out how to get tampons in women's bathrooms. And we're like, can we fix the physician fee schedule?
Yeah, that's true. So I mean, the best one, a couple of years ago, there was a sweet little medical student who, or resident, I think she was, who had a resolution. What she wanted was warm, culturally sensitive meals between 11 p.m. and 6 a.m.
Yeah, and how old was she?
I don't know, maybe 21, 22.
Exactly. That's my point. Because half the people going to the AMA meeting are not even practicing physicians.
But they are culturally sensitive, and I would defend them. At least they come to the meeting.
Yeah, well, you're right. You're right. And I'm a big proponent of getting involved and doing something if you don't agree with how it's getting done, and hence working healthcare. So Dr. Arthur Palamara, thank you for joining me.
My pleasure. It's a pleasure being here. I'm honored to be here, actually.
Well, good. I'm glad you're honored. I'm honored that you joined me. I'm honored that you drove through this crazy rain and we're having this very late podcast. So thank you.
I would have walked if I had needed to.
Thank you. To everyone listening, the full video of this episode is now on YouTube. Search Working Healthcare and hit subscribe so you don't miss future interviews, short clips, and behind-the-scenes moments. Got a question, an episode idea, or someone you think I should feature? Drop me a line at meredithhirsh.com. If this conversation hit home or made you think a little different, don't keep it to yourself. Share the episode, tag a friend, or post about it on social media. You can follow Working Healthcare on Instagram, Facebook, and YouTube. And connect with me on LinkedIn. That's where we keep the conversation going in between episodes. The more voices we bring into this space, the more momentum we build, because change doesn't start with a policy. It starts with a real conversation, like this. New episodes drop every Tuesday. Subscribe and don't miss what's next, because you can't fix the U.S. healthcare system until you understand it. I'm Meredith Hirsh. Tune in weekly with me as we explore the inner workings of healthcare.